Good morning and welcome to the Virtual Infectious Disease Congress sponsored by Johns Hopkins University School of Medicine on ID Care Live. My name is Karen Marr, and first let me apologize for my tardiness this morning. I'm 100% responsible. I was just a tad bit lost in downtown Baltimore, so I'm happy to be here and thank you for being patient. So you're tuned into the live CME session called Immunocompromised Hosts and Opportunistic Infections with a focus on prevention. I'm a professor of medicine and oncology and the director of transplant and oncology infectious disease at Johns Hopkins University. And before we get started, I'd like to first remind you that I'll be taking questions throughout the presentation. Actually, I'd like to spend more time during the presentation and then address most of the questions afterwards. I will repeat the question if you send them in and address them verbally. I'll be addressing them in the program through a box in the lower left-hand side of your screen. So that's kind of the introduction. Thank you all for your questions and for your participation. It's very important for the success of this program. I'd like to thank Genentech and Cubist for their support of this important educational series. Please remember to complete the quiz at the end of the session to secure your CME credits. Again, my name is Dr. Karen Marr, and thank you for joining me. So this morning, we'll be talking about immunocompromised hosts and opportunistic infection with a focus on prevention. And here are some important disclosures. I've been an advisor and a consultant for numerous companies, as well as received grant funding from the entities that are listed. Let's start thinking about the subject of immunocompromised hosts. And just in a general state of mind, I think the first thing that we need to do is to really address the issue of definitions, because the definition of immunocompromised has really changed over time. There are obvious states that we know to be associated with immune compromise, such as HIV infection, transplantation, various therapies for malignancies. But there's also many other conditions that are more common in primary care practice and in other medical specialties and in the population at large. And those include the elderly population, people with diabetes, people with low-grade hematologic malignancies such as myelodysplastic disorders. And one of the most expanding population of patients that is immune compromised right now are these people that are being exposed to pharmacologic therapies that are largely now biologic therapies, for instance, for autoimmune diseases, inflammatory bowel diseases, and so forth. And this is really a growing number of people that we have in our population currently. Let's also think about what opportunistic is. And the definition there has changed, and it really depends on what you consider to be an opportunist. Previously and classically, we considered opportunistic infections to be caused by organisms that don't otherwise cause diseases in people that have healthy immunity. I think that that's a little bit more of a dogmatic definition than what really applies to our field right now. Because probably a current and more pragmatic definition when we think about our infections is probably an infection that occurs at increased frequency or severity, depending on the immune response of the host. And this is how I define opportunistic infections. And so if you're following me, you can probably understand that that really can cover any infection. And so I'm not going to be talking purely about the infections that occur only in people that have compromised immunity, but the ones that are most common and the ones that we see in practice. So my goal specifically is to review infections that occur in immunocompromised hosts that are seen most frequently in the practice of people who are participating in this program. And so it's not usually people like me who do transplant and oncology infectious diseases. People that are doing general infectious diseases, internal medicine, and so forth. And it really can encompass many disease states, many infections. I'm going to focus on the clinically important and potentially preventable infections that we need to recognize clinically, both to prevent them up front and to include them appropriately in our diagnostic algorithms. Here's my outline. I'm going to first talk about the most common immunosuppressed hosts in our populations right now in those clinics, and those include elderly patients and people exposed to biologic immune suppressants. I'm going to spend a good bit of time talking about those drugs because they're expanding and confusing, and a lot of questions arise. I'll talk about several different infections, opportunistic infections, if you will, in the context of receipt of those immune suppressants, tuberculosis, as well as non-TB mycobacteria, and I'll cover some of the issues that arise with regards to latent and endemic fungal infections and the questions that arise there. And then I'm going to shift and talk specifically about other infections that we need to be thinking about for prevention algorithms in immune suppressed hosts, and largely those caused by herpes viruses, herpes simplex virus, VZV. I'm not going to be focusing largely on CMV. I'll talk as well about pneumocystis because that's an increasingly problematic issue and an infection that really can be prevented. First, focusing on common immunosuppressed hosts. Now let's think about the elderly. You know, this isn't the population that we frequently describe as being immune suppressed, but actually it is. And as people age, we're starting to understand the relative immunosuppression and the mechanisms of relative immunosuppression that occur during the latter years. And I would suggest that aging actually is a potentially immunosuppressive state in itself. And there's been a lot of studies that have looked at this. It impacts general risks as well as responses to vaccines at multiple different levels. And it's, of course, the phenomenon that we frequently refer to as immune senescence or aging of immunity. And there are multiple levels of immune dysfunction, if you will, that can occur in people when they age. And the figure here, I think, is a really nice schematic that was published in a CID article in 2008. Because it shows the multiple levels at which there's an alteration of immune response, specifically to vaccine-acquired immunity. And that's, of course, a very important issue when focusing on prevention of infections in the elderly. And the levels include multiple different cells. Of course, it can involve presentation of antigens. There's defective or inefficient presentation of many antigens with regards to function of dendritic cells. Of course, the lack of T cell production can and thymic involution actually that occurs after many years of being alive is associated with depletion of naive T cells. And so what is impacted there with regards to vaccine-acquired responses is the relative inability to generate a new T cell immunity or cell-mediated immunity to antigens that the person hasn't been exposed to before. What also that does is actually restrict the repertoire of antigens that one can respond to, even with different types of vaccines. There's also a relative depletion and lack of production of B cells, and that, of course, impacts antibody-mediated immunity and the type of responses that one can generate, both to infections that are acquired as well as to vaccine-acquired immunity. Multiple different levels, and then you get into bone marrow function and the relative quieting of bone marrow that occurs in aging hosts. So I think that the schematic really nicely shows the multiple levels at which our immune system changes during this period of senescence or aging. The other thing that actually puts people at risk for multiple different kinds of infections, of course, involves different organ systems and different diseases that are acquired over time, and probably the most important would be lung disease. So here's the most common infections that occur, and that's largely pneumonia, urinary tract infections, skin infections. People as well are at risk for reactivation with other latent organisms, and the most common is reactivation of varicella zoster virus. They as well are at increased risk for reactivation with other organisms, such as Mycobacterium TB or other endemic mycoses. The other infection that is very important in the elderly population, of course, is gastroenteritis. There's a lot that has been written about increased risk for infections, for instance, and morbidity acquired by C. difficile infection. Most recently, one of the things that has gained a lot of attention, of course, is the potential impact of norovirus infections in the elderly population. And that's a setting in which, of course, we see a lot of different outbreaks in chronic care facilities, as well as, for instance, nursing homes. And so I'm not going to focus on gastroenteritis and C. diff or norovirus, but I will talk about some of the issues that come into play with regards to organisms that cause pneumonia. And I'll spend a lot of time later in the talk about reactivation with latent organisms with those three entities shown. Before we get there, though, I'd like to present to you this table. And this is a table that summarizes the type of vaccine efficacy that you can anticipate in elderly patients that are vaccinated with multiple different vaccines that we currently have available. In the left-hand column, you've got the vaccines that we have available. The middle describes the vaccine type that we have, and the numbers that are listed on the right-hand panel are the proportion of patients that are anticipated to have an effective or to mount an effective response. And I'm showing this table because it presents not only specific data, but I think that you can really appreciate how our responses anticipated in the elderly population are really not sufficient for protection. Influenza virus vaccines that we currently have are working on the order of about 50% efficacy. Hepatitis vaccines somewhere between 30 with hepatitis B subunit vaccines to 60% for hepatitis A. Herpes zoster, one of the most important problems here, about 2/3 or 64% efficacy. So you can understand here in looking at that table that, of course, we've got problems with regards to really getting a good protective response with the typical vaccines that we have. And not to leave it out, the pneumococcus vaccine, the non-conjugated polysaccharide vaccine, the studies have shown that the percent efficacy in elderly people range from 50 to 70%, possibly with an enhanced response with the conjugated vaccines. But in general, I think that what is being demonstrated in this table is that they're not good, and that's a real problem. One of the biggest problems that we have, of course, is influenza virus infections. And since it's so timely right now, in November, nearly December, approaching this season, in some places we have some active activity, I thought that I'd review this and what we could anticipate. Remember that most deaths associated with flu in industrialized countries are actually in the elderly as well as other immunosuppressed people. And it really should be considered in people during the wintertime, regardless of the presentation of disease. It's something that we need to have a very heightened sense of suspicion for in people, especially with febrile syndromes. Annual vaccines are recommended, but not totally protective, as we just reviewed. For one reason, it's of course the immunocompromised elderly are not likely to mount a sufficient protective response to the vaccine. And of course, the other factor involved is what applies to all of the population, which is the antigenic variation that we see in the hemagglutinin and neuraminidase antigens that are involved in each seasonal vaccine. And for these reasons, of course, there's going to be disease. Remember, though, that presentation can be variable. Fever, myalgia, headache are the classic symptoms that occur in the population that is infected with influenza. But in the elderly, people can mount coughs, fever. Altered mental status is actually very, very common. GI complaints, these are the types of things that can occur and should point you in the direction of thinking about flu as opposed to other respiratory viruses. And I would submit to you that it's becoming more and more and more important to establish a diagnosis as we are entering the age in which drugs actually do work to prevent progression of lower tract disease. The alternatives that we have include rapid antigen testing, but the sensitivity only approximates 50 to 60%. Keep that in mind. You're not going to rule out the flu with that test. There are other multiplexed assays, specifically RT-PCR assays, that will detect respiratory viruses. And we use this a lot in the hospital, especially in the population that is immunocompromised. I know at Hopkins several years ago, we started using the multiplexed assays for everyone who presents with a respiratory virus type of syndrome in the setting of any kind of immune compromise. And the utility there is not only the enhanced sensitivity for detecting influenza, it's the ability to detect other respiratory viruses and to differentiate between the two. And this is important because early therapy is really indicated in order to prevent development of severe disease. It's also indicated to prevent prolonged shedding, which of course presents a problem epidemiologically, especially in outbreak settings. Remember that elderly people have an increased likelihood of developing pneumonia as well as secondary bacterial pneumonia. So it really is an important and a severe infection that warrants therapy when the infection is diagnosed. And even in the setting in which you have a predictive syndrome and a negative diagnostic test, those people can benefit from early empirical therapy directed against influenza virus. I want to shift from the elderly into the pharmacologically immunosuppressed population and the types of things that we anticipate seeing in that immune-suppressed population. We've seen a lot of people, of course, that receive corticosteroids for multiple different types of underlying disorders, and that promotes a generalized immune suppression. I'm not going to talk about the specific risks associated with steroids, but what I want to do is to present a functional understanding of the new biologic agents and the type of infections that present as opportunists in the setting in which people are exposed to these drugs. This is becoming increasingly complicated, and I think that I hear it a number of times from all colleagues, and that is that no one can really keep straight the multiple different antibodies that we're using for multiple different conditions, whether that's in the hematologic population or in the rheumatologic population. These drugs are expanding and expanding. There are things to understand and some general concepts that I'd like to present here. I listed some of the targeted monoclonal antibodies there. They include antibodies that target CD25, CD20, rituximab, IL-1 receptor inhibitors, IL-6 receptor inhibitors, T-cell co-stimulation inhibitors, CD52 inhibitors, CTLA-4, and the large group of drugs that inhibits either TNF-alpha, multiple different drugs there. And what I want to focus on is the TNF-alpha inhibitors as well as the monoclonal antibody against CD20 because of the expansion of the population that is really seeing these drugs right now. But I want to present two important concepts. One is that immune suppression is really not cumulative, or is cumulative. It's not specific. We frequently go into this and say, okay, what can I expect when someone is exposed to a TNF inhibitor? And the answer isn't that simple because the risks are really a cumulative function of everything that person has seen as well as their underlying disease. And I'll present some scenarios in which this comes into play diagnostically. The other thing to keep in mind is that the risks for infection are really not entirely clear from the data that are generated from registrational clinical trials. And the reason I'm bringing this up is that if you go into package inserts and try to effectively educate yourself on the infectious risks, for instance, associated with TNF inhibitors, you're not going to get the whole story. And that is because a lot of our understanding has come from our experience in phase 4 setting, largely from multiple different country registries, as people have been exposed to these drugs in multiple different parts of the world, and the numbers have expanded. So keep those two things in mind when trying to interpret and understand specific risks. TNF inhibitors. There's a lot of them. There's monoclonal antibodies that work specifically against TNF-alpha, and they're listed on the top line. There's a pegylated FAB fragment of a monoclonal antibody against TNF-alpha, and there is a soluble receptor. I'm sorry, there's a misspelling there for TNF-alpha. Of course, that's etanercept. And these are approved for many indications: rheumatologic arthritis, rheumatoid arthritis, psoriasis, inflammatory bowel disease, ankylosing spondylitis, as well as utilized in other different conditions, for instance, in the transplant setting. Remember again that these drugs are not the same. We've had certain drugs for a longer period of time, and they include infliximab and etanercept, and some of the comparative data that we have really focused on those two drugs. And what you can say is that etanercept has a shorter half-life and probably a less robust inhibition, and probably a decreased association with different opportunistic infections, and the risks are potentially later with cumulative exposure, but the trends are the same. And the trends are that these patients have a high risk for reactivation with intracellular organisms and development of opportunistic infections, especially those that are prominently mediated by macrophage function. And that includes classically tuberculosis, non-TB mycobacterial infections, and histoplasmosis. And I'll talk to you as to why I think that histo and TB are particularly important with regards to these drugs. Other opportunistic infections that are described more often include coccidiomycosis, cryptococcosis, listeria, bacteremia, as well as meningitis, nocardia, and interestingly enough, infections with other filamentous fungi such as Aspergillus species. Why is it important for predicting risks for tuberculosis? Well, I like this review by Kevin Winthrop, which was in Nature Clinical Practice in Rheumatology. And it summarized data up until several years ago, however, and there's some things that we've been aware of since. But remember that TNF-alpha is needed to preserve granuloma formation and macrophage killing. And that's particularly important for TB as well as histo. So the inhibitors are associated with high rates of reactivation as well as extrapulmonary TB. If you actually look at the data, the median date of onset after exposure to infliximab is about 3 months. The median date of onset of TB reactivation associated with etanercept exposure is much later, probably about a year. We all agree, however, that this is a setting in which screening and treatment in infected people is really the best thing to do. The current recommendations include 9 months of INH, standard treatment of latent TB, 6 months of INH or rifampin. Screening is an issue, and it's something that we question a lot because of the irony here. It's very important to screen patients in the setting in which they're going into TNF-alpha inhibitor exposure. However, this is usually the population in which the yield of screening may be the worst. And so it's very important here to understand our alternatives. And one of the reasons why is because of the increased utilization of ELISpot assays that are more specific and potentially more sensitive. So classically, screening consists of tuberculin skin testing or PPD, as well as a chest x-ray. Anyone who has a greater than 5 millimeter induration with recommendations by the CDC should receive treatment for latent TB. If you're in a country that has a population that's been largely exposed to BCG, then some of the recommendations have been a larger in duration. You know, the availability of interferon release assays, IGRA's, an example here is the quantiferon gold assays, has really changed the way we can approach this. These are ELISpot assays that utilize a pool of TB antigens that provide more specificity to TB, and so BCG does not elicit a positive response. There's a lot of other complications to using them. One of the most important is the complexity involved in cellular processing, and there's a lot of controversial recommendations. But right now, the recommendations are to use these assays in people that have had prior BCG vaccination, people that have a negative PPD or skin test but still have high risks for infections. And this is a hard population to describe, but clinically you know who they are. They're people with prior exposure, the people that you have had indications that have probably been exposed to TB in the past. And it also includes immune suppressed people and people with other conditions that would predict a poor response to skin tests. And here's where the irony again comes in. This is in the population that we're talking about here now, as well as the transplant population, people with hematologic malignancies, as well as people with chronic renal disease. And these are populations in which we know that the utility of the PPD is lower. However, keep in mind that the performance of the IGRAs in this population is going to be impacted by the same disease states as well. However, there are numerous studies that are being published in a number of different populations that do suggest that performance, follow-up performance using an ELISpot assay is probably a good thing to do. One of the infections that is very important here are actually the non-TB mycobacterial infections. And there's some indication, in fact, that they may be, in fact, more common than TB reactivation itself. And Kevin Winthrop did this passive surveillance study through the Emerging Infections Network and just asked people to report the numbers of NTB, non-tuberculous mycobacterium infections versus TB infections. And in fact reported that the non-tuberculous infections were twice more often than TB. Now, this is a little bit problematic data, right? Because most of the time we remember the TB infections because we have to report them to other authorities. And so there is a lot of potential bias in this kind of reporting mechanism, passive surveillance mechanism. It's the same thing that comes into play with regards to reporting the actual risks for other infections such as histoplasmosis, ones that are not reportable to public health. But keep in mind that these are at least common. Mycobacterium avium complex, M. chelonae, abscessus, and marinum are in that order the most common that were reported in that study. Think about this. The bottom line is that they occur, and think about them especially in people with consistent syndromes, and especially in people that have had a lot of other immune suppression in the past, especially with corticosteroids. I want to transition from mycobacterial infections to fungal infections. And this is kind of the stepdaughter in the field. These are important infections, but don't have the same public health significance as TB. So there's a lot more controversy as to what we do to prevent them or even diagnose them. But I do want to present these infections because they really are becoming more apparent as being problematic in people that are exposed to TNF inhibitors. One of the most important, I believe, is Histoplasma capsulatum. This is the species that is endemic to certain regions of North America largely, as well as South America. This is and the map that characterizes the region of endemicity is shown on that bottom left-hand panel. Keep in mind, though, that our data that generate that understanding are really very, very old, dating back to the 1960s, large surveys using skin tests that may or may not have had the sensitivity that we need to really understand the type of exposure that we can expect. Although we say that this is in the Ohio, Mississippi river valleys, and you can see the large hotbed of exposure there, it's been my observation, especially in recent years, that probably the endemic zone is broader, and I would say covers at least parts of Pennsylvania, Western Maryland, and we've had a large number of people that have been referred to us recently from certain parts of Delaware. And so I've got a real interest in trying to revisit that map of endemicity and exposure. Keep in mind that it's essentially everywhere other than the Northwest. This is a syndrome that is really very, very similar to TB, both with regards to how it presents and the pathogenesis. These are organisms that grow in the environment as a mold, are acquired into the lungs and transition morphologically into a yeast form. That yeast form is gobbled up by macrophages that go into the local lymph system and then get filtered into the reticular endothelial system and end up in different parts of the body, the liver, the spleen, the bone marrow. That sounds like TB, doesn't it? It's almost exactly the same kind of pathogenesis, and the very unique features of these infections is that these are organisms that can live latently in those cells. And so they can set up and be in check with granuloma formation in the reticular endothelial system or the lungs, but they're not dead. And that's where they reactivate, and that's how those syndromes become apparent. And that's really why I put these infections kind of into the same category. TB, if I think about TB diagnostically, you've got to think about histo at the same time, especially in people with the same kind of risks or with the endemic risks. Now the problem is, what do you do with histo in this setting? You've got someone who's going into an at-risk period. In this scenario, we're thinking about TNF inhibitor exposure. It could be really anything else. We don't have any clear guidelines with regards to the utility of screening like we do for TB, and I think that there's two reasons. One is that we probably don't have as good a diagnostic test for histo as we do for TB. Our tests now for latent infection rely on antibody detection in blood, and they're not very sensitive, even with the best technology that we have available. We don't have the ELISpot assays, and we don't have skin tests. And I think that this is a real big gap in our diagnostic algorithms that we have currently. The other is that these are organisms that don't have the same public health significance in the setting of reactivation disease. And so there's not been the same kind of efforts to put that together. The other infection that I want to talk about is coccidioides. People talk about these in the same sentence as histo, and I'm not sure that they really fall into the same category. They have different pathogenesis, different exposures, and different presentations. These are, of course, organisms that are endemic to the southwest United States, and they're acquired as a mold from the environment and can reactivate after being transitioned into different morphologic forms in the lungs as well. Again, the diagnostics are not as widely available. They rely on antibody recognition in the blood, and there are skin tests available. There's some controversy as to the utility and the efficacy of those skin tests. And the question is, what do you do when you find that someone's had latent cocci infection in an area at risk before going into TNF-alpha inhibitor, and that we don't know? Other fungal infections that you have to think about diagnostically, but that we probably don't have effective preventative algorithms for. Filamentous organisms, they've been described in this setting quite a lot, as well as cryptococcosis. And I'm putting this diagram up here just to remind everyone that cryptococcal infections are really endemic infections as well. Although Cryptococcus neoformans is thought to be ubiquitous, there's probably hot spots in different regions. Cryptococcus gattii, which is of increasing concern in North America, is certainly endemic to multiple different parts, and specifically to the Pacific Northwest. You know, that region of endemicity for Cryptococcus gattii does reach down into the southern parts of the West, and we're seeing cases reported in multiple other states as well. Probably no implications with regards to screening and prevention, but you've got to think about these infections diagnostically. I want to transition from TNF-alpha inhibitors to rituximab exposure, and that's because it's a drug that is being increasingly used for a number of disease states: rheumatoid arthritis, lupus, ITP. This is a drug that targets CD20 and thus causes a 6 to 9 month depletion of B cells. Now, when we first started using this drug in our randomized studies, we really didn't think that there were any specific infectious risks. However, in meta-analysis and in phase 4, what we've learned is that there is a higher relative risk for opportunistic infection, but the bottom line is that that's in the population of people that also have some impact in cellular immunity. In other words, the observation is especially apparent in people that have other underlying diseases such as HIV infection that have received rituximab, for instance, for lymphoma. And in that setting, there are multiple different enhanced relative risks for opportunistic infections that cover CMV, non-TB mycobacteria, PCP, PML. Prophylactic considerations come into play, and the things that we can prevent are fungal infections, candidal infections, as well as pneumocystis. Screening for CMV is probably an issue. One of the most important things to remember is that these patients, by virtue of receiving the anti-CD20 antibody, have a high risk for hepatitis B, and that's what needs to be screened for before receipt of these drugs, because that's a setting in which prophylaxis is indicated. I want to transition here to other reactivations to think about. And this is just my opportunity to review other features of disease and immune suppressed hosts that I think are important to understand. And I want to focus first on herpes viruses. Now remember that all viral infections can be severe in immunosuppressed hosts, even though, for instance, for respiratory viruses, there may not be an increase in attack rates, for instance, of the flu. That has a lot to do with exposure, but there's a potential increase for severity, morbidity, development of lower tract disease in these settings as well. When you consider herpes viruses, they're unique because you've got the feature of reactivation from latency. When these viruses infect humans, they go latent into sensory nerves or other cells in the case of CMV, but risks for disease and severe disease are higher with immune suppression. And the other thing to remember is that these are potentially preventable. Now, I just want to talk about HSV and VZV here because it's important in this population. HSV 1 and 2 are more common to reactivate oral and genital lesions in the setting of immune suppression, and this is the population in which other complications occur: disseminated disease, recurrent meningitis, cranial nerve palsies. It's also the setting in which we've not really adequately understood or evaluated the utility of prophylaxis. And of course, this is outside of the HIV and transplant populations where it has been evaluated. Remember, though, that resistance can become an issue when especially putting acyclovir at low doses on and off during periods of reactivation. VZV reactivation is more common and severe. The things to keep in mind is it really can be multidermatomal, disseminated, and CNS disease, as well as organ disease in the most immune suppressed. Prevention in select populations is a good idea, and what we have are vaccines and prophylaxis to do that. The vaccines are used most frequently in the elderly population. There's the reactivation of dormant zoster is common due to immune senescence. And remember that the vaccine works as a booster to the cell-mediated immunity. In other words, the virus is already there, but what we're doing is boosting periodically cell-mediated immunity. It's a live attenuated virus that does prevent decreased morbidity. We use the varicella vaccine in kids, and the higher inoculum can result in latency and more disease. Both, however, are contraindicated in immune-suppressed people. And here's how the ACIP defines immune suppression. There's a lot of little caveats in that population there, and it covers a lot of the people that we're talking about here. Just remember that there's some controversy as to who can receive this vaccine, and ironically, it's in the population that needs it the most. I want to end this talk with some discussion on pneumocystis. And remember that this is a fungus, and it's a fungus that infects people early in life. Disease is a pneumonitis, and How it occurs is really not clear, but we're learning much more with regards to the natural history of disease. Some of it is appearing to be latent disease. Newly acquired infection occur in cell-mediated immunity are typical defects in cell-mediated immunity are typical risks. What we've learned recently is that there's probably more likelihood of person-to-person transmission of pneumocystis than we ever expected before, and that's an observation that's become apparent especially in cohorts of kidney transplant recipients in Europe. What about in other immune-suppressed populations? Well, it looks like probably there's a potential of decrease in the morbidity here, and these have been reported in rheumatoid arthritis, where a UK study has really documented a person-to-person outbreak and suggested that when one sees a lot of disease, even in a state such as RA, that may be a setting in which more widespread prophylaxis can be a good idea. Other associations are rituximab, steroids, Wegener's, lupus. Remember that infection can be very atypical with more granulomas presenting as opposed to a flat-out pneumonitis that we see in the HIV-infected population. That as well has an impact with regards to the utility of diagnostics that rely largely on fungal burden. We don't know how to prevent it, but there's some indications that we should be doing it in a larger population of people at risk, and some recommendations, for instance, from Japanese consensus groups that suggest that we should be giving prophylaxis at least twice weekly to populations that were anticipated to have any defect in cell-mediated immunity. And here's where a lot of controversy and confusion comes in. So I'll stop here and just summarize. There's an expansion of outpatient population of immunosuppressed people. And this is really incorporating multiple conditions and therapies, has real implication with regards to screening and preventative therapy, especially in people that have latent infections that include herpes viruses, mycobacteria, latent fungi. Remember that the utility of screening and prevention in this setting really relies on a risk-benefit ratio that is unique to every individual. So here I'll stop and see if we can generate some questions and answers and some feedback from the participants. Thank you very much. I've got a computer in front of me that will summarize questions as they come in. And okay, here we go. How long is voriconazole given post-transplant? Well, that is a very interesting question, and it depends on what kind of transplant and what we're trying to prevent. I think that that's not an easy question to address here. Depends on the risk-benefit ratio and who specifically you are talking about. Email me if there's any questions with regards to that, because I'm not sure I can address it here. What is the significance of aspergillus seen on a BAL? Great question. The significance is that you've got aspergillus in the airway. And so the interpretation is, what does that mean? And I think that the scenario is very similar to CMV infection. For instance, you can ask the same question, what's the significance of CMV reactivation? If it's in a healthy people that's not immune suppressed, then it's really probably not significant. There's nothing to prevent. If it's in someone who has a significant defect in cell-mediated immunity, then is very significant. In this setting, what you find is that you've got fungal elements in the airway. It just means that people aren't clearing the aspergillus effectively. We need to go the step further and ask the question, how at risk is that person for local airway disease caused by aspergillus or invasive disease? And that's where it relies on the unique function of cumulative immunosuppression. So I think that it really depends on who that is. In many settings, I agree that that's something that should be treated preventatively. Urine histoantigen, does it not have utility? of course, it does absolutely have utility, and it looks like there are certain laboratories, it's made available in multiple laboratories, especially in the US. The Miravista is the most commonly used reference laboratory, where Joe Wheat has really done a good job in optimizing the antibody-based testing for urine histoantigen. Remember that the histoantigen is probably a galactomannan that is excreted into the urine. It's present in the blood too, and can cause some false positivity and cross-reactivity with other galactomannans. However, it takes a lot of histo to have antigen in the urine. And so in people that just have latent infection, you're not going to find a positive antigen. In fact, it looks like there's a large proportion of people that have even just histo in the lungs that don't have a positive antigen. And so in the setting of not severe disease or even focal pulmonary disease, it's got questionable sensitivity. I'm clicking through these questions here. Are there prophylactic recommendations for patients on a TNF inhibitor? I think that I covered, or was my intent to cover, a lot of that. The clear preventative indications are for people with latent TB. For the immune suppressed, at what point of continued herpes virus replication or viral loads can you look for antiviral drug resistance? You know, it really depends on the virus. If you're talking about CMV, then that presents a very different issue. If you're talking about herpes simplex virus 1 or 2, then it's very complicated to try and interpret viral loads. And however, I've seen acyclovir resistance occur with people that have had multiple reactivation events with HSV. Been involved with the care of one patient recently in Pennsylvania who appears to have an acyclovir-resistant recurrent HSV infection. But this was picked up by recovery of the virus and phenotypic testing. So I think that's a complicated and a good question. Would I recommend annual PPD tests prior to Remicade treatment for inflammatory bowel disease? I think that the utility of annual testing really would involve interpretation of exposure risks. I do think that people that have Remicade therapy for inflammatory bowel disease, and again, it depends on cumulative immunosuppression, can be substantial. And so I would recommend PPD testing in people who would be people that would normally do screening tests on them. That would be anyone who has risks, for instance, with regards to known exposures or healthcare and so healthcare exposure, so forth. In general, how do I use fungal antigen assays such as the beta-D-glucan and galactomannan in my practice for preemptive or preventative therapy? You know, I think the antigens assays are very, very useful. There's a lot more data from the galactomannan assay. We talked a little bit about identification of Aspergillus in the airway. The same issues come into play, which is that you have to go the next step and try and ask the question of the significance of having a circulating fungal antigen in this setting, galactomannan. It's very, very useful for anyone at risk for aspergillosis. Not very sensitive, really, but a positive is really informative if you really suspect invasive disease. The beta-D-glucan assay, there's a lot less that we know. It's less specific, obviously, because you've got glucan on a number of fungi. But I think that we're going to find in the future that it's going to be very useful for detecting early disease as well. Now, unfortunately, I was not able to go to or get to all of your questions, and for that I apologize. I want to close at this point. They're telling me that I have to, otherwise I'd sit here and do it, I promise. I want to thank you for your questions, your participation, your interest, your time. Like to also thank Genentech and Cubist for their support for this educational series. Please remember to complete the quiz at the end of the session. They're questions that I developed. They're pretty easy in order to secure your CME credits. My name is Kieran Marr. Thanks for joining me this morning, and I wish you an absolutely lovely day. Thank you very much.